Hello, welcome everyone. Thanks for joining us for today's webinar on cardio-renal complications of type 2 diabetes, the link between cardiovascular and renal disease. This webinar is presented by ADCES in association with AstraZeneca, the U.S. Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for this webinar, and handouts are not being distributed. If you would like to ask a question during the presentation, please type it into the Q&A box on your screen at any time, and we'll answer as many of your questions as possible during the Q&A session at the end. So I'd like to introduce our guest host today, Dr. Curtis Triplett. He is a certified diabetes care and education specialist and associate professor at the University of Texas Health Science Center at San Antonio. So we're very excited to have him here with us, and I will turn it over to Curtis to introduce today's speaker and give us an overview of the webinar. Curtis?
Well, thanks, Megan. I certainly appreciate everyone being here today. I know much of the U.S. is getting some bad weather, so I hope this broadcast finds you safe and warm. Today, our webinar is really going to concentrate on some of the recent cardiovascular outcome trials in type 2 diabetes and what we can learn from these important trials about heart failure and diabetic kidney disease. We'll also look at recent trials using SGLT-2 inhibitors as treatments specifically for patients with heart failure and chronic kidney disease, both with and without type 2 diabetes. And finally, we'll present an overview of updated guidelines. Our presenter today is Dr. Karthik Linganathan, who is a cardiologist with AstraZeneca. It's now my distinct pleasure to turn it over to Dr. Linganathan to begin.
Thanks, Curtis, and thanks for the opportunity. Welcome, everyone. So what we're going to look at today is cardio-renal complications of type 2 diabetes and what's the link in between. Now, so when we look at what are the common complications in diabetes, every one of us knows here, it's macrovascular and microvascular. You see all the complications here starting from blindness, end-stage renal disease, pancreatitis, stroke, and you see the cardiovascular complications, MI, and peripheral vascular disease. You also see congestive heart failure. From a Medicare database, they looked at to see, do patients with diabetes compared to the patients without diabetes, do they have excess number of events? And if they really do, which one of these complications do they have the highest excess number of events? It's interesting when we looked at it because everyone would assume it's cardiovascular, right? And probably it's something related with acute coronary syndrome or MI. But it's interesting, it's congestive heart failure had a highest amount of excess events. By numbers, it was 185 events per 1,000 patient years compared to roughly 85 events per 1,000 patients year in patients with non-diabetes. So there were 100 excess events, and that's what CHFS shows, almost 100 events. What is shown here is end-stage renal disease. I want to point out end-stage renal disease and not CKD or chronic kidney disease. And we want to differentiate that because we want to see how common are cardiovascular and renal changes in patients with diabetes. So when we look at patients with diabetes, when we think of heart failure and LV dysfunction, changes in the heart, we want to first see if a patient has well-controlled diabetes, do they really have changes in their heart? So this is one of the studies called short wave study where they took almost 386 patients. They did a stress test. These are diabetic patients, 5 years of diabetes, hemoglobin A1C was pretty decently controlled at 7.1. They actually did the stress test, made sure they didn't have any ischemia, and they followed the patient. They said, okay, let's look at the echocardiogram and see what percentage of patients did have some kind of LV changes, LV dysfunction, either systolic or diastolic dysfunction or both. They found that almost 68% of the patients had some kind of LV dysfunction. And this is not the only study. There are other studies which mirrors the same thing, which shows almost 60% of the patients have changes in the LV function. And these are well-controlled diabetic patients over a period of 5 years. Now, when we look at diabetes and heart failure, we want to also think about what are the stages of heart failure. And because when we think of heart failure, we always think of patients ending up in the hospital on IV diuretics and terribly short of breath. But heart failure is a disease process. There is a stage A heart failure, but patients with diabetes by just being diabetic, and we're going to see why, comes into stage A heart failure, which is still preclinical, they don't have any symptoms, and no obvious symptoms. Then a stage B heart failure where something similar to what the slide here shows, they have a heart failure, they have diabetes even well controlled for a period of time, and they start to develop LV changes in the left ventricle. And these are not due to ischemic changes. They are not because of ischemia, and that's what the study shows. It's not ischemia, but just because of having diabetes. These are preclinical changes, asymptomatic patients still, before they go to stage C heart failure, which is what we normally see, a patient ending up in the hospital with shortness of breath. So is that when we talk about patient with diabetes, is it only the cardiac changes? What about changes in the kidney? And this is from the UK PDS study, and they had 5,100 patients with diabetes. They observed that the progression from micro to macroalbuminuria and progression from normal to microalbuminuria is almost 2 to 2.8% per year. Roughly in 15 years, 38% of the patients developed albuminuria. Almost 28% of the patients developed stage 3 CKD. That is your CKD with the GFR less than 60. See, these patients are still in a preclinical state, right? I mean, these are not symptomatic patients, but it shows you by having diabetes how you still continue to have these changes both in the heart and kidney, leading to asymptomatic changes, leading to preclinical stages of heart failure, and in my mind preclinical stages for kidney disease as well. So now when we talk about these cardiac and renal changes, we think of cardio-renal syndrome. So when we think of cardio-renal syndrome, everybody, one common thing we always think is, oh, cardio-renal syndrome, meaning that the heart, anything that affects the heart changes something in the kidney, and anything that affects the kidney affects the heart. And that's very true. But in diabetes, it goes one step above, meaning by being diabetic, you have abnormal cellular changes. We're going to look at it both in the heart and kidneys. That is an ongoing process. That's what you saw as stage A or stage B heart failure, but it's still preclinical. They're not in the hospital, but the changes are ongoing. They're still asymptomatic. Similarly, in the kidneys, your initial stages of chronic kidney disease, they are not symptomatic. The changes happen. What else happens in a patient diabetes is what you see in the green box in the middle. They also, by being diabetic, you have sodium retention, you have volume retention, you have significant renin-angiotensin activation, which leads to increased fluid load, whether it's preload or afterload or whatever in terms of the heart, increased fluid overload. There is significant neurohormonal activation, including sympathetic activation. We know in diabetes, we have increased inflammation, ischemia, and altered energy changes. So all this put together, you have patients who chronically develop this asymptomatic initial heart failure and renal stages. And by virtue of being diabetic, what you see in the green box, it slowly pushes them into more clinical stages. So this doesn't happen over one day. This just happens over a period of time. You have a well-controlled patient, well-controlled hemoglobin A1C. So in a patient, how does this stage A, stage B heart failure happen? So is it just ischemic process? Is it just coronary artery disease? Not necessarily. So there is increased prevalence of what we call as diabetic cardiomyopathy. Diabetic cardiomyopathy is when diabetes affects your heart muscle in different ways by either increased inflammation, impaired calcium handling, fibrosis, LV hypertrophy, and changes. So the heart generally starts to thicken. We saw as LV dysfunction, slowly then starts to dilate, leading to decreased ejection fraction. So that is called diabetic cardiomyopathy. And eventually what we see is going through those stage A and stage B heart failure is the stage C heart failure, which you see on the right side, where patient ends up in the hospital. So diabetes causes these molecular changes. What about kidneys? It's the same thing. Even though we're trying to simplify here, by diabetes, it causes by a similar process laid for from the cardiac status. It actually does a couple of things. It causes mesangial expansion in the kidney, in the glomerulus, capillary membrane thickening. It also causes segmental effacement of food process. These processes will lead to the slow thing. We talk about changes in albuminuria. From normal to micro to macroalbuminuria. They're still asymptomatic patients, right? and changes in GFR over a period of time. So, Curtis, I want to take a quick moment and then get your thoughts on something. Like we saw, given that diabetes patients in early stages of either it's chronic kidney disease or stages of heart failure, like stage A and B, don't have any major symptoms. But in your opinion, how do we need to think about prevention of heart failure or CKD in this really asymptomatic patients? How do we really think about this?
Well, it's a great question, and I think one of the things that we really need to think about is just screening. I think that even though there's not symptoms, we still have some things that we can do to, especially for diabetic kidney disease, to kind of look at the underlying problem. So, for example, we can do our yearly EGFRs. We can do our yearly microalbumin screens to make sure that we're catching things early if someone's at risk. Heart failure, I think, is a little bit harder because it has, as you had just said, so many inputs. So it's kind of like a leaky dam. If you put your hand on one of the problems, then the other problem starts to rear its ugly head. So I think heart failure prevention is a lot harder, but CKD prevention is pretty easy. Obviously, for heart failure, one of the things we think about is blood pressure a lot. So, but that's just one of the different components. Back to you.
Oh, thanks, Curtis. That was really great example, and I agree with you. And KDIGO guidelines actually, when got updated on early screening, exactly says what you're mentioning. Screen them early, screen them sooner, screen them often to make sure that you address this earlier. Don't wait for clinical symptoms. And heart failure approach has similarly marked into same way. And we're going to look at studies as well that just the glucocentric approach might not be enough in the diabetic patients, because these changes, like we saw with the even stable hemoglobin A1C, they seem to still progress. So we might need to modify and think of this something differently and add treatment that actually helps in the process of prevention of both heart failure and CKD. So now these are, what's seen here is what are the common risk factors for heart failure. Everything is listed here: obesity, hypertension, dyslipidemia, chronic kidney disease. Now, what is very interesting, and obviously diabetes is a risk factor for heart failure like we saw, but what is very interesting is just by the virtue of having diabetes or being a diabetic patient, all of us know almost 70% of those patients have 3 other comorbidities associated with them. Like most of them, almost 70% will have probably hypertension, obesity, and dyslipidemia. So being a diabetic patient, you already have 3 other comorbidities associated with that. So you are, by being a diabetic patient in a patient sitting in front of you, this patient has significant high risk for heart failure. In the same circle diagram, if you just put, instead of heart failure, chronic kidney disease, it's pretty much similar risk factors that are also associated with chronic kidney disease. So by virtue of being a diabetic patient, 70% of them have other comorbidities, and these comorbidities, along with diabetes, puts you at a very high risk of heart failure. So it's not just a diabetic patient, but it is a patient who have a set of comorbidities which puts them at a high risk of subsequent cardiovascular and cardio-renal complications. Now, what we see in this slide is, at different GFR cutoffs, what is the risk of end-stage renal disease, and what is the risk of CV death events? We know almost close to 50% of the events in a renal, 50% of the events that happens in a CKD patient that leads to morbidity and mortality is due to cardiovascular events. We know that. So does it change based on your GFR? Answer is yes. Both end-stage renal disease, progression to that, and a cardiovascular event significantly increase as the GFR drops. So when it drops from 45 to less than 30, you see those bars significantly are higher. What is also interesting is if you subsegment this data with adding albuminuria and say if a patient has more albuminuria across the board, higher the albuminuria in each of the GFR cutoffs will also significantly increase your both progression to end-stage renal disease and CV death or cardiovascular events in general. So then we ask a question, when we say cardiovascular events, what kind of cardiovascular events happen? Now, in a patient with with and without CKD. What you actually see here, these blue bars are patients with CKD, and green bars are patients without CKD. And you see different cardiovascular events. You see coronary artery disease, acute myocardial infarction, heart failure, CVA and TIA, and so on and so forth. What you see is a patient with CKD has a high risk of those cardiovascular events. It's not just one was another. Obviously, we saw how heart failure is significantly higher, and similar is coronary artery disease. So that is probably the reason patients with CKD have almost 50% of the events are some kind of cardiovascular event. Now, is it just mortality? Is it also morbidity in a patient who has CKD? The answer is both. When we look at the data presented here, and what you see is on the left side, the CV events and the different GFR cutoffs. You see GFR, less than 15. You see different categories which correspond to different status of CKD. And now you see the number of age standardized rate of cardiovascular events. You see there is significant increase in events in patients with end-stage renal disease. It's almost double compared to your stage 3 kidney disease, more than double compared to stage 3 kidney disease. And same thing happens with hospitalization. It's just not mortality events, it's morbidity events. So by preventing the progression from stage 3 down to end-stage renal disease, the concept of prevention, you can actually significantly decrease this morbidity and mortality due to cardiovascular events. So, I want to take a quick minute before we go further. I want to ask a quick question. Now, there is, a common feeling among healthcare providers in general that just treating those risk factors in diabetic patients would prevent the progression or occurrence of heart failure and CKD. But definitely in heart failure literature, we know that's not true because there are meta-analyses that took UKPDS and Barrett and all the studies and showed that even when controlling the risk factors or controlling hemoglobin A1C very tightly, still the heart failure macrovascular complication, especially the heart failure, still seem to progress. I just want to hear your thoughts on, is that treating just the risk factors good enough, or what else do we need to think about when we think of these progression to both heart failure, cardiovascular, and renal events?
Yeah, it's a great question, and one that we ponder a lot. When you're looking at a lot of these clinical trials, I mean, the risk factor control is pretty good. With blood pressure is pretty well controlled, cholesterol pretty well controlled. You go down the line of things that you want to control, and they do a pretty good job of that. And despite that risk factor control, people still get heart disease, people still get heart failure, people still get CKD. And, some of that is what you had mentioned before, is that there's such a complex underlying pathophysiology to the development of all these. And so I think it behooves us as healthcare professionals to realize that anything we can do on top of that, for example, in the last 10 years, until SGLT2s showed up, we really didn't have anything above an ACE or an ARB to prevent CKD on top of glucose control and blood pressure control and those kind of things. And we were still having lots of CKD, and the same thing for heart failure. So I think the underlying pathophysiology says, just because you're controlling risk factors does not mean that you're not going to have one of these deleterious outcomes.
I completely agree with you, Curtis. That is very, very true. I mean, yes, risk factor control is important, but that just doesn't solve the whole issue of progression of these diseases, underlying other diseases that happen with diabetes. I mean, it's just one more step, and hopefully in the through this rest of the presentation, we can hopefully look at those aspects too. Thank you for that. So now let's look at before we look at the data. And look at data from SGLT2, GLP-1, so on and so forth, and anti-diabetic agents. Why did we even start this path, right? When glitazones came in 2000, and then we slowly start to see the link between anti-diabetic agents and heart failure and cardiovascular events. And so one of the questions that came to FDA, and one of the things that FDA decided in 2008 was, the guidance to industry was, we need to start looking at safety of those events, CV safety of those events, of those agents, any of the anti-diabetic agents that's going to come to the market after that. So that is what started all the studies to look at cardiovascular events. But what, to our very pleasant surprise, what we're going to see is what we saw was actually opposite. We saw significant benefit from cardiovascular and renal standpoint in those new agents, especially in SGLT2s and GLP-1s, and we're going to start looking at it. Now, the goal is not look at every one of those agents, but the goal is to actually get a bigger overview of those agents to understand what kind of benefit they have and where do they get benefit when you talk about cardiovascular and renal. Now, what this slide shows is a meta-analysis taken of all the GLP-1 data. If you look at, you see the bars extending on either side. If you look at the bottom, you actually see when it's to the left, meaning that it favors GLP-1. You see most of those bars actually are to the left. They actually favor GLP-1. It means that in these are MACE events, looking at MACE events in all the GLP studies. And they found that almost there is a 12% significant risk reduction in MACE events in all the GLP-1 studies put together. So what about SGLT2? Now, these are different studies. SGLT2, DECLARE, dapagliflozin, CANVAS, canagliflozin, EMPEROR, empagliflozin. And there are two categories. First, I want to make sure we address the categories. So each one of the studies, depending on underlying population, had two sub-category of patients. One category was patients just with multiple risk factors. These are your diabetic patients, like which just might be hypertension, smoking, dyslipidemia. What we saw, normally it's almost 60-70% of diabetic patients associated with that. Those are multiple risk factor subgroups. Then there was another group which is established CV disease. They had some kind of known CV disease, MI, cerebrovascular disease, or even some of them had known heart failure from before, 10 to 15% depending on which study you look at. What is interesting is when you looked at the MACE events or the benefit in MACE events, population that had the patients who had known established CV disease, you actually see on the top, they had significant benefit in reduction of the MACE events. When you look at multiple risk factor subgroups, which was covered in DECLARE and CANVAS study, you saw a trend towards benefit, but you didn't see the significant difference. So there's something to keep in mind. Now, what about GLP-1? We saw GLP-1, there was significant benefit in MACE events, but when we start to similarly subcategorize based on the available studies to patients with established CV disease and patients with multiple risk factors, do you see benefit? And obviously, one thing is common that, patients with established CV disease tend to always have significant benefit. Now, there are multiple meta-analyses that have looked at it. In general, there is benefit across the board. Obviously, the benefit is more seen in patients with known CV disease from before in terms of reduction in MACE events. Now, as the studies were coming out, what initially started looking at secondary endpoints, because they were looking at CV events, was hospitalization of heart failure. What they observed then became very interesting. Then they looked at even as a primary endpoint later across these studies, similar studies, the DECLARE, CANVAS, EMPEROR, these are all diabetic patients. And the same categorization, there is established CV disease or multiple risk factor subgroups. What you see is consistency of the benefit, meaning that whether a diabetic patient was just a multiple risk factor subgroup or they had known established CV disease, it didn't matter either of those groups, they had significant reduction, almost 30% reduction in general across the board in hospitalization of heart failure in all these SGLT2 studies. Now, what about renal benefits in SGLT2 studies? Was there renal benefits? Now, there were different kinds of composite renal benefits were looked at. It's not necessary to go into depth of what exactly, but most of them looked at, GFR slopes. Most of them looked at change in GFR, like 40% change in reduction in GFR. They looked at, end-stage renal disease as one of the endpoints of renal death. What is interesting is across the SGLT2 study, the same studies, DECLARE, CANVAS, and EMPEROR, whether they were multiple risk factor subgroups that established CV disease, all of them had significant reduction in renal endpoints across the board. Now, what about GLP-1? Did they have any renal benefit? Answer is yes. Similar meta-analysis done across the board on multiple GLP-1 data, and the composite endpoints, are either combination of new onset albuminuria, sustained doubling of serum creatinine, or 40% decline in GFR, end-stage renal disease, or renal death. What you see is consistency of data. There is significant benefit of all these renal endpoints or composite renal endpoints across all the GLP-1s. The only thing to notice, there was almost 17% total reduction, significant reduction in those composite endpoints. It was noted, if you look at the GLP studies, it was driven more by proteinuria with some modest GFR improvement or GFR benefit. So it was driven more proteinuria. That might be one of the reasons you're going to see later in guidelines how SGLT2, which seemed benefit across the board, seemed to be even compared to GLP-1 in renal, in terms of renal events, seems to be somewhat preferable. And might be one of the reasons is that how the GLP-1 studies showed the benefit was more proteinuria and with modest benefit in GFR changes. Before we go here, Curtis, again, I want to jump back to you and ask you, another question to understand the data we saw. What we saw in my mind was a consistency across the board in GLP-1 space and SGLT2 space. GLP-1 being most benefit in MACE events, SGLT2 showing benefit in hospitalization of heart failure and renal events differently. But one of the common questions I always get is, that's great, it's a lot of data, but it seems consistent, that's wonderful. But when I'm seeing a patient, a diabetic patient sitting in front of me, what do I just focus on? Do I think of MACE events to prevent? Do I think of heart failure to prevent? Do I think of CKD to prevent reduce the progression? What do I need to focus on? Because there is so much data across the board, even though the data seems to be consistent. I would like to hear your thoughts on how you think when you see a diabetic patient sitting in front of you.
Yeah, I think that when you're seeing someone with diabetes, first things we do categorize them based on primary prevention or secondary prevention. And I think, in the primary prevention space, one of the things that we often think about is the fact that, as you said, we want to control risk factors. But then if the risk factors are under control, we have to look at what is the most common thing that happens. I work in a predominantly Hispanic population. It seems to have a lot of risk of CKD. So we might kind of go towards prevention of CKD more than prevention of MACE. So we might think mostly about an SGLT2 inhibitor. But, we also have to incorporate in glycemic control. So if the person is 1.5% A1C from goal, I might consider that person more of a GLP-1 receptor agonist person if they're willing to inject. I don't have many people, but if they absolutely positively refuse to inject, we might go back towards the SGLT2 inhibitor. So I think you have to individualize to the patient, patient-centered, oriented. Look at their history, look at what there might be at risk for. A lot of our Hispanic patients have a strong family history of someone in their family either having a MACE event or having CKD. So that also may influence our decision about going one way or the other.
Thanks, Curtis. That was really great. I mean, this goes back to the root of what we normally do. As you said, patient-centric is not one size fits all. It depends on other things the patient might have, or we project probably might develop based on the previous history that helps us to choose one or another. Thank you for that. Now, I want to look at, mechanism of action of SGLT2. Now, this slide is, I really apologize, and I'm sorry this slide is too complicated. There are too many things and arrows back and forth. But I'm going to try to simplify the mechanism. There are almost 20-some mechanisms of SGLT2, and we're not going to focus on all that. We're going to just drill down to something that could be just simple to understand. How does it benefit in terms of cardiovascular, especially heart failure, and how does it benefit in terms of reduction of renal events? Now, SGLT2 inhibitor inhibits SGLT2 receptor, which is actually in the proximal tubule of the kidney, as most of us know. And once it inhibits that, it prevents absorption of glucose and one molecule of sodium. It leads to glucosuria, which leads to osmotic diuresis. In a diabetic patient, that's almost 70 grams of glucose. And it also leads to increased sodium load to the distal tubule. This increased sodium load to the distal tubule leads to tubular-glomerular feedback, leading to afferent arteriolar vasoconstriction. And this will drop the glomerular pressure. This subsequently will change the intrarenal RAS mechanism, decrease sympathetic activation. So along with all this, what happens because of somewhat of osmotic diuresis, changes of sympathetic activity and change in afterload and change in preload, there is a benefit in terms of heart failure, right? Because preload and afterload plays a huge part in heart failure. So when you reduce your preload and afterload, the stage of the clinical heart failure goes down significantly. And you're going to actually see the studies that actually show that. Similarly, when you drop the glomerular pressure, and that's one of the bigger ways, obviously there are other mechanisms, which leads to benefit in renal space. And we're going to look at the studies, especially, and the studies that we looked at some studies, but look at studies that are specifically in CKD patients and how it actually gives benefit in terms of renal endpoints. Now, this slide is a lot of details, but instead of drilling into details, what we want to focus is on, like we did for previous data, more consistency and what are the common things that have been studied in SGLT2 space in HFrEF patients. So now we are slowly moving away, just not totally a diabetic patient, but more towards heart failure patients. These patients are heart failure patients with reduced ejection fraction, meaning their ejection fraction is less than 40%. There are three studies that were done: DAPA-HF with dapagliflozin, EMPEROR-Reduce with empagliflozin, SOLIS with sotagliflozin. We're going to focus more on DAPA-HF and EMPEROR-Reduce here. But constantly across the three, there were things that were common. All these patients had heart failure with ejection fraction less than 40%. All of them had some elevated NT-proBNP, just to make sure they're all heart failure patients. They were on great standard of care. All your normal heart failure therapies, whether it's ACE inhibitors, ARBs, MRAs, it doesn't matter. They were beta blockers. They were on all those wonderful therapies, and almost significant percent of patients on wonderful therapies. And the other common thing across those studies, especially DAPA-HF and EMPEROR-Reduce, which we're going to look at further, is significant number of patients in the studies did not have diabetes. So the studies had both diabetic and non-diabetic patients. And what you will see is consistent benefit in reduction of CV death or hospitalization and even renal endpoints in these studies in these patients. Now let's look at DAPA-HF, dapagliflozin study, where they used 4,700 patients. They were heart failure with reduced ejection fraction patients. 43% of the patients had diabetes. 55% of the patients did not have diabetes, and they were on 10 milligrams of DAPA or placebo. They were on all those patients. All the patients in both groups were on good standard of care. Almost 90% of the patients, higher 90% of the patients were on ACE, ARB, your beta blockers, and 70% on MRA, so on and so forth. What is more important is the primary endpoint, the reduction in primary endpoint. Even in these well-treated patients, even in these patients with or without diabetes, there is something consistent among them with this benefit in the primary endpoint, which is 26%. 26% significant relative risk reduction in the primary endpoint with a number needed to treat of 21 in terms of reduction in CV death or hospitalization of heart failure. There is a significant benefit. And, there was benefit in all-cause mortality, benefit in recurrent events, and the safety data of SGLT2 was pretty consistent with previous safety data. And what is more interesting, what I want to point out, is patients without diabetes. In patients without diabetes in the studies, they did not have any significant or serious hypoglycemia or serious TKA. So that's interesting. Now, if you look at EMPEROR-Reduced, similar construct. Now, 3,700 patients. These are the patients with heart failure, reduced ejection fraction. 49% of the patients, almost 50% of the patients had diabetes. Almost 50% of the patients did not have diabetes. These are very, very well-treated group of patients. The same thing, they were randomized to either empagliflozin plus standard of care or placebo plus standard of care. What you're going to see is similar data, which shows almost 25% significant risk reduction in the primary endpoint, which is CV death or hospitalization of heart failure. So there is this consistency of data of benefit of these agents, which we initially saw as diabetic agents, but even in non-diabetic patients give benefit in reduction of the primary endpoint, which is CV death or hospitalization of heart failure. Both those studies also had benefit in GFR slope, showing benefits in renal endpoints as well. So that is your heart failure space. where we saw SGLT2 benefit in patients who already had heart failure. Now, what about CKD space? What about SGLT2 inhibitors in CKD space? What we're going to see is, Credence, we're going to look at DAPA-CKD, this EMPA-Kidney, which is still not, the results have not been read out, and FIDLIO-DKD. Now, FIDLIO, we're just going to leave it for a second. Let's just focus on SGLT2 inhibitors. And we're going to look at the studies. What is found among all the studies? Credence had all diabetic patients. DAPA-CKD had both diabetic and non-diabetic patients. Similarly, EMPA-Kidney has diabetic and non-diabetic patients. All of them had some UACR cutoffs. I mean, each one of them had different cutoffs. UACR and Credence was between 300 to 5,000, and DAPA-CKD was 200 to 5,000. And similarly, in EMPA-Kidney was greater than 200, and different GFR cutoffs, but in Credence was greater than 30 was accepted. In DAPA-CKD was greater than 25, and EMPA-Kidney was 25 or higher, and the cutoffs are stated here a little different for patients. What all they commonly looked at when we're going to look at especially Credence and DAPA-CKD is the renal composite endpoint, which you look at, it's almost pretty similar. Doubling of serum creatinine or greater than 50% sustained GFR release, and end-stage renal disease, renal or CVD. What we're going to see is consistency of the data across again. So this is Credence, canagliflozin. Diabetic patients with increased UACR, 300 to 5,000, and CKD patients given canagliflozin 100 versus placebo. What is the consistency of data? There was 30% significant relative risk reduction of the primary endpoint. And you see the renal specific endpoints here. And you also see there's a 31% relative risk reduction, as you see below, is in CV death or hospitalization for heart failure, and which you're going to see in the other DAPA-CKD study as well. And the all-cause mortality, there's 17% reduction in all-cause mortality. Now let's look at DAPA-CKD. Similar construct, these patients are CKD, GFR 25 to 75 cutoff, UACR was between 200 to 5,000, and these patients, similar to Credence patients, were very well treated patients. They were on ACE or ARB greater than 4 weeks, so they were maximized on those underlying therapies which we normally use for CKD, and then they were randomized to dapagliflozin or placebo, and you will see the 39% significant reduction of primary endpoint, which is change or reduction GFR 50% decline or end-stage renal disease or renal or CV death. And similarly, you will see that 29% reduction in CV death or hospitalization of heart failure, and 31% relative risk reduction of all-cause mortality. Consistent, again, consistency of data across CKD patients. The difference between the Credence and DAPA-CKD, as we pointed out, is DAPA-CKD included both diabetic and non-diabetic patients. But what you see is consistency of the data. EMPA-Kidney is still not read out, but the underlying, the patient population, it's almost similar. You have patients with different GFR cutoffs. The lower GFR is 20 and higher, and they're all maximized on underlying therapy, and then they were randomized to empagliflozin or placebo. And you see the primary endpoint is similarly, kidney disease progression or CV death. So before we go to, guidelines and look at updates and guidelines, what we saw is consistency of the data and the benefit in the SGLT2 in cardio-renal space. Curtis, I'm just going to, turn back to you and ask another quick question. One of the things we do see especially in SGLT2 inhibitors is because they cause afferent arteriolar vasoconstriction and lead to decrease in glomerular pressure, there is a drop in GFR in the first 10 to 14 days. It's consistent across the studies. Either we look at diabetic studies from before, we look at DAPA, like heart failure studies, or now CKD studies. There is anywhere between 3 to 5 ml, change in GFR in 10 to 14 days, and it seems to get better. And we saw the long-term benefit, renal benefits of these agents when they kept on. But obviously, there's a common concern. There's a common concern when the GFR and changes happen or drops, and the creatinine increases in 2 weeks after the SGLT2 initiation. I would like to hear your thoughts on how do we really address that concern, because we do see a long-term benefit of these agents.
Yeah, so it's important for people to understand that just like with RAS blockade, you have an initial reduction, and what you're actually doing is, most people know, is that you're kind of offloading the glomerulus. And when you offload the glomerulus, the pressure within the glomeruli goes down, and you're going to see this initial drop. But the offloading of the pressure on the glomeruli is what's benefiting the patient. And so what happens is over time, per se, as an EGFR starts to climb back up again, and usually it goes back up to baseline, or, at least anecdotally in a lot of our patients, we see that the EGFR goes above baseline where they were at. So we've had some really nice improvements in EGFR long-term with these agents. And so, I think it's important for people to understand that if you want to check at 2 weeks to see the lowest number possible, go ahead, but it's not clinically going to benefit you. We're really looking at long-term prevention here, and the short-term minor drop in EGFR is usually not that important.
Thanks, Curtis. That was great. Thank you. And as you said, we see a long-term benefit of these agents, and the same etiology, same rational physiology that causes GFR drops actually probably the physiology, along with other mechanisms that actually help to reduce the primary endpoints, the end-stage renal disease and renal CV death and other endpoints we see in this patient. So thank you for that. So now we are starting to look at guidelines. I know in the next few slides we're going to look at the guidelines. I know all the slides are crowded, and the goal is not to go into depth of every guideline. That's not the goal. The goal is, to look at consistency across the guidelines. Consistency, what is the guidelines across the board, whether you take, diabetes guidelines or your ACC/AHA guidelines or PCP guidelines, what is consistent among them? What is consistent actually truly is what we actually noted so far, is there is benefit of this agent in reduction in CKD and heart failure, and we saw in the ASCVD as well. And this benefit is not just the glucose control, it's more than that. There are other mechanisms that are actually in play to cause that. So all the guidelines are consistent in saying that, you want to look past just a glucose-centric approach. You want to use these agents in patients either at higher risk or who have your established CV disease or, heart failure or CKD. And that's what you're going to see across those guidelines. Now, this is your 2020 ADA Standards of Medical Care, antihyperglycemic guidelines. Obviously the first line of therapy is metformin, but then the guidelines branch on and says, do you have indicators of high risk or established ASCVD, CKD, or heart failure? If you do, then what do you really do? Look at the first thing after S. It says, consider independently of baseline hemoglobin A1C or individualized A1C target, meaning that you look past the glucose-centric approach, and then if you still think that it's an ASCVD predominates, then you do GLP-1, or SGLT2, but preferable GLP-1, and that probably stems from all the MACE benefits we saw GLP-1. But if this heart failure or CKD predominates, then we saw in SGLT2 data, both from meta-analysis and subsequent studies we saw in SGLT2, preferentially use SGLT2 or GLP-1 if the patients don't tolerate SGLT2. So what's consistent is not just the glucocentric approach, assess for risk of those the disease process, or if they have disease process, and use these agents, which are, as we saw in all those meta-analysis studies, are going to provide those benefits. Now, we're just going to break it down in simple, the ADA guidance. So if you're a heart failure patient, diabetic patient, you're already on metformin, then what else do you need to do? If your ejection fraction is less than 45%, you're a heart failure patient for heart failure, then regardless of baseline hemoglobin A1C or individual A1C target, you want to add SGLT2. And what about CKD? Same thing. If the DKD and albuminuria is present, we saw in all those studies, they had some of the albuminuria, they are your DKD or CKD patient, diabetic patient. You want to, regardless of the baseline hemoglobin A1C or individual A1C target, you still want to add SGLT2 in this patient because of the significant benefit, not just in those renal endpoints, but benefit even in the cardiovascular endpoints, even in those renal patients, CV death or hospitalization for heart failure. Now, what about ACE guidelines? I know it's complicated and all of us have probably seen this guidelines, but what I want to focus is the box in the middle. Again, independent of glycemic control, if established ASCVD or high risk for CKD or heart failure reduced ejection fraction, you want to use GLP or GLP-1s or SGLT2. So there is some consistency across the board in these diabetic guidelines. Now, what about primary care position statements? Do they say anything different? Answer is no. If you look at the box, if they are very high risk, diabetic patients are very high risk for heart failure or CKD, what it says is consider SGLT2 alongside rather than stepwise if they have heart failure CKD. So it again goes back to the point of don't just look at the hemoglobin A1C and then stop working on the patient, because these patients still have the progression of the disease process, underlying progression. To prevent that and help with the process, you might want to add SGLT2 agents. So it's not just stepwise but alongside. So what about 2020 ACC expert consensus decision pathway? Did it say anything different in a patient, especially a patient in diabetes? You will see the same consistency. Look, if you look at the red box that is there, if the GFR is acceptable, right, consider initiate SGLT2 with proven ASCVD, heart failure, or DKD benefit. And the agents are listed below, and those are the studies we actually looked at. And the same thing if they are ASCVD predominantly, because the MACE benefit in GLP-1 agents, you want to use those agents, and it talks about specific agents where they found the studies are even more robust. So on and so forth. But there is consistency across the board. Now, before we go to this slide, and I just want to, Curtis, turn to you again and ask your opinion on this. And, all these guidelines have been considered on some things like we saw. One is, yes, management of glucose is important, but don't just stop with glucocentric approach. Always look past hemoglobin A1C as the only cutoff to add or change medication. And more importantly, with the significant cardiovascular renal benefits in those agents, you might want to still add those agents, sometimes even alongside, not even sequential, say in other guidelines. But the common thing comes across is how do we move the healthcare providers to move from this only glucocentric approach? How do we move them from glucocentric approach to more prevention of cardiovascular renal benefit approach based on all these guidelines and data so far? I would really like to hear your thoughts.
Well, yes, I think one of the things that's most important is for people to understand what's going to hurt your patient the most in the short term. When probably the ADA is the most a little bit behind some of the other groups. The ACC guidelines are a little more progressive. Even the ACE guidelines are a little more progressive. And what they do is they seem to put up front what is the most important thing, which is heart disease, diabetic kidney disease, which of course is if you have microalbuminuria is a huge cardiovascular risk factor, and if you have macroalbuminuria, the risk of going on to have end-stage renal disease. These are the things that will kill your patient. We always are concerned with glucose, but we have to understand that glucose complications happen over decades. But what will kill your patient and not let them come back next visit is uncontrolled cardiovascular risk factors. So we have to put what's most important up front. And that means addressing cardiovascular risk factors first. That means addressing diabetic kidney disease first, because these are the things that will kill your patient a lot quicker than glucose.
Thank you, Curtis. I completely agree with you. I mean, these studies and the consistency of the data across the board, consistency of the guidelines have all stated the same thing you're saying. Just look past this glucocentric approach, but look at the patients as patients, diabetic patients with high risk of cardiovascular renal events, and these disease process, underlying disease process is progressing, whether we see it or not. They are in asymptomatic state, whether it's renal or cardiac, Unfortunately, by the time we see it actually becomes too late because they end up in the hospital either with unfortunate kidney failure or with significant stage A heart failure. But we do have a huge lead time where we can actually prevent it if we look past just a glucocentric approach and add these agents appropriately in the patient care. The last slide I want to actually see and then talk a little bit about is what Curtis had actually talked about. And what is now everybody can understand that why do we need to look at, or think about heart failure and CKD in these patients, even though the patients are not complaining of symptoms. And KDIGO guidelines and early identification algorithms have actually really come around to actually say that. And that's what I want to point out, like Curtis said. If your patients, the conditions that increase CKD risk are present, diabetes is shown here, hypertension, diabetes, CVD, obesity, old age, and so on and so forth. If they are there, you want to start screening them. Consider screening. Use your albuminuria, look for serum creatinine, cystatin. And then if it's positive, then, any of the following is present, then you just recheck in 3 months. And, this screening will help to find these patients with GFR is constantly trending down, where the USCR is present higher than 30 or it's going to increase, and you have other markers of CKD. You want to identify these patients, you want to treat these patients sooner. Because once you start treating these patients and taking those angles, you prevent not just the progression of renal events, progression of kidney disease, progression of CKD, not just renal death, but you even prevent significant cardiovascular events, which is almost 50% of costs in a CKD patient, CV death or hospitalization. As you see in the red box on the side, I just want to point out, it actually reads, SGLT inhibitors recommended as a first-line treatment with metformin and may also have benefits in persons with CKD and no diabetes. So every one of those guidelines constantly have caught up to this, and it's interesting to see that every one of them is consistent along, and goes back to what Curtis said is early screening. So to summarize what we saw, early identification of patients for heart failure and CKD in a diabetic patient is very important, plays a pivotal role because we have something we could do for them, add appropriate management for them so we can prevent the progression of disease process, which might be asymptomatic at this point, would be all of us know and all of us have seen become symptomatic at some point. So, and what we saw was consistency of data of all the CVOT studies, whether it's GLP-1 or your SGLT2 across cardio-renal space. There is consistency of benefits. Now, obviously, effective options of choosing each of the agents might depend on what its exact population was studied and so on and so forth. There's granularity of data, but on the bigger picture, there is consistency of the data across the board. And we saw something else as well. We saw in a diabetic patient whether this patient has just multiple risk factor subgroups, the patients, diabetic patient will come in office patient with just other risk factors, which is hypertension, dyslipidemia, or obesity, and so forth, or diabetic patient with known cardiovascular disease process from before, all of them benefit across the board with this agent. Benefit across the board. So next time, it actually shows how a diabetic patient setting in an office is at risk for so many of those events, and how you can actually prevent it. And I just want to say thank you for this opportunity, and I really appreciate it. And I turn it back to Curtis and Megan.
Great. Thank you so much. So we've got time. We'll take a few questions here, and we've already got a number of questions in, so let's jump right in. The first question I'll direct to Karthik. So SGLT2 inhibitors seem to work so well for diabetes and diabetic kidney disease. So why do I need other agents for glycemic control when the eGFR drops to 45 and below?
That's a great question. That truly is a great question. So we saw how SGLT2 inhibitors act to reduce the mechanism of action, right? So we saw that SGLT inhibitors inhibit SGLT2 receptors, which is in the proximal tubule of the kidney. So it has secretors to go to the proximal tubule, it has to inhibit the SGLT2 receptors. And by causing glucosuria, it actually effectively costs almost 70 grams loss of glucose in a day, which is almost 350 calories roughly. And that glucosuria leads to effective reduction of your glucose and better control of your hemoglobin A1C, which it does really well, almost 1 to 1.4, depending on which studies and how you look at it. But once the GFR drops below 45, as everybody can understand, you can't really rely on these agents after that completely for control. Yes, they probably do control, but we can't rely on those agents for glucose control. That is different from their cardiovascular renal benefits, because those benefits still happen, because those benefits of other mechanisms like we talked about will still happen. It is only the glucose benefit. If we are using that for just for glucose benefit of those agents at the point, then we might need to add other agents for glycemic control. I don't know if Curtis has anything to add that.
No, that's perfect. I mean, yeah, I mean, people, as you said, we need to get out of the glucocentric understanding and understand that the reason we added is for diabetic kidney disease. That's why we add the SGLT2 inhibitor, whether it does or does not lower the glucose.
Great, thank you. Curtis, a question for you. Besides mycotic infection and getting regular lab work and foot exams for a controlled type 2 diabetes patient, what side effects should be watched for with SGLT2 treatment?
Well, I think in general, SGLT2 inhibitors are very well tolerated. I think that when you look at the data of an SGLT2 inhibitor versus ones that most people think are extremely well tolerated, such as a DPP-4 inhibitor, you find equivalent discontinuation rates between an SGLT2 inhibitor and a DPP-4 inhibitor. And I think what that tells you is, in general, almost all patients, other than what you just mentioned, tolerate SGLT2 inhibitors very, very well. In fact, a lot of our, it's anecdotal, but a lot of our patients come back and tell us they feel better on an SGLT2 inhibitor. Perhaps that's due to the diuresis effect. Perhaps it's due to other effects. I don't know. But I just know in general the discontinuation rates are the same as DPP-4 inhibitors. And in general, people tend to like them. Back to you. And
great. Thank you, Curtis.
Yeah.
I agree with
Oh, sorry. Go ahead.
No, I agree with that. Yes, they are very well established safety profile across the board. That's very good. Thank you.
Great, thank you. I think we've got time for one more question. Karthik, regarding prevention, is it logical to assume that someone is likely suffering from both cardiac and renal issues, or can they occur independently of each other?
So, thank you. That was a great question. And as we saw, in a diabetic patient, these issues progress hand in hand. They constantly go on, right? I mean, those changes due to inflammation or glycemia or insulin-related changes happen both in renal, parenchyma and glomerulus, and at the same time in the cardiomyocyte as well at the same time. And if we also saw in a diabetic patient, there are other factors that happen which leads to volume overload, sodium retention, which is independent of these molecular changes that are happening at the same time, right? Which actually lead to progression and accelerate those events from preclinical stages, whether it's stage A, stage B, heart failure, which is preclinical, or the earlier stages of CKD, which is still patient doesn't have any symptoms, to more symptomatic state. So to answer your question, they go hand in hand, and we also know cardio-renal syndrome, which as one is progressing, getting worse, there is a crosstalk between heart and the kidney. The other will get worse or progress and go accelerate faster. So they always go hand in hand.
Wonderful, thank you. Well, I want to be cognizant of our time here, so I think we'll go ahead and wrap up. But really want to thank Dr. Karthik Ranganathan and Dr. Curtis Triplett for presenting today and providing your wonderful input and perspective. And thank you all for attending today's webinar. This webinar was recorded, and it will be posted on our website, diabeteseducator.org, at that link on your screen, also under the education dropdown on our main page. It will be available for only 90 days, so make sure you check it out. And save the date for the next webinar in this series, which will be on April 7th, and we will open registration very soon. So thank you all. This concludes today's presentation.